Today we will talk about medically compromised patients management, how to manage these patients in the clinic, specifically cardiovascular patients, bleeding disorders and anticoagulants patients, endocrine patients, and then pregnant patients. So, the general principles always we should go with the basic principles. The chief complaint, the history of the chief complaint, the medical history, dental history, social history, the examination, extraoral and intraoral, the investigations. Then, with all of those, we will get the diagnosis and we will get to the treatment plan, and then we can go on with our treatment. But the first step that we have is do no harm. We should be always going to protect the patient and do no harm to him or her. Now, the general principles of management always a medical consultation, sometimes it's a must. Sometimes it's a must to go for patients for medical consultation with the patient's physician. We should have a short, minimally stressful appointments in an upright position, and anxiety, exertion, pain should be minimized. Now, we prefer patients with cardiovascular diseases to go through late morning appointments to have the lowest level of endogenous epinephrine desirable. An aspirating syringe should be used always, and we should always be careful with adrenaline containing local anesthesia because they can cause hypertension and cardiovascular complications later on, and we will talk about them in a minute. Cardiovascular diseases include ischemic heart disease, hypertension, arrhythmia, prosthetic valves, infective endocarditis, and heart failure. An ischemic heart disease in which there is ischemia, there is reduction of the blood flow and the oxygen to the heart. The heart, in the end, it's a muscle. The pathophysiology of of the diseases and all of that were explained in a previous video. So, angina and MI. Angina is an imbalance between oxygen demand and oxygen supply to the coronary arteries. So, the amount of oxygen that reaches the area, that reaches the coronary artery, does not equal the demand that we need. There are three types: stable, unstable, and vasopastic. Vasopastic. The stable is the most common form in which there will be pain upon exertion, pain upon stress, pain upon work. That's where we have, and it once the patient takes his rest or takes his nitroglycerin, the pain goes away. Unstable angina, less common, but the pain is spontaneous and does not relieve with rest. So even if the patient takes a rest, it will not go away. The patient will still be in pain. The patient will still have the pain coming out spontaneously. Vasospastic, sorry, coronary artery spasm or Prinzmetal's angina. It's very rare and it happens during the night when the patient is asleep. Usually, the coronary artery gets a spasm, it gets narrowed, it gets tightened, lets blood going through to the area which causes the angina and the chest pain. But then it goes away by itself. Now, risk factors they can be irreversible or reversible. Fixed factors like male gender having a higher risk, more with older age people, and ethnicity. The reversible such as high LDL, hypertension, and smoking. Another system of classification involves primary, secondary risk factors, and protective risk factors. The primary risk factors like the high LDL, hypertension, and smoking. The protective factors like raising the HDL, more exercise, and moderate red wine or other alcohol in a little amounts can help, according to studies. Now, the clinical features there will be heavy, crushing in nature chest pain that radiates to the shoulder, to the arm, to the neck, to the jaws, and sometimes associated with dyspnea and shortness of breath. This is the classic angina pain. Now, the management for angina usually goes through antithrombotic or antiplatelet therapy, anti-anginal medications, modification of cardiovascular risk factors, protecting more protective factors, increasing the HDL, reducing the LDL, changing the lifestyle of the patient, and procedures like CABG or percutaneous coronary intervention. Now, usually for medical management of these patients, sometimes we might need medical consultation, of course. Late morning appointment, we try as much to reduce the stress. Local anesthesia is more protective and more safe than general one. We try to treat the patient in an upright position. We usually use aspirating syringe with adrenaline. Now, patients will be on nitroglycerin and aspirin, most of them. Now, aspirin, we don't stop the medication. We go with our procedure with the patient on it. Now, if there is an emergency and the patient started to have the chest pain, we stop. We turn away anything that might injure the patient. Then we let him rest. If the patient gets better, that's great. You send him to the ER to deal with him. If not, we try to give nitroglycerin, we try to give aspirin 300 milligrams crushed. This is an MI, a myocardial infarction. Another way, we should call 911 the first step. So if there is an emergency, we start by calling 911, then resting the patient, stopping our procedure, giving him nitroglycerin sublingual, and waiting on the patient. If the patient gets better, it's a stable angina. The patient should be fine, but still he should go to the ER. If not, then it's an unstable angina or myocardial infarction. So in both ways, we should send the patient to the ER to have a procedure for him, to have an MRI, a CT scan, CT angio, all of the possible investigations that might be needed. Now, the myocardial infarction is an irreversible damage to the myocardium due to prolonged ischemia. The ischemia has been there for a long period of time. There are two types, the ST elevated and the non ST elevated. Usually, the ST would be totally blocked coronary artery, the non ST elevated partial blockage. The clinical features similar to the angina but more severe. Now, we should take the history of the patient when the MI happened and what was the procedure done for him. Coronary stents. The stent is a mesh that keeps the artery open, like this one. This does not need any antibiotics or all of that. Now, back then in the day, they said we should wait at least a year before a myocardial infarction. So if the patient had myocardial infarction, we should wait a year until we can do any elective procedure for the patient. Now, then they made it 6 months, and now lately they said we can do it after 1 month of the procedure, but given that it's in hospital-based setting. So if there is anything wrong to happen, the patient can be dealt with in a proper way. Late morning appointment and upright position as always. Local anesthesia with adrenaline. The general anesthesia, it's risky. It increases the risk of having it again. Now, patients would be on antiplatelet medications and antithrombotic or anticoagulant medications like warfarin, heparin, novel anticoagulants, which we will talk about later on. If there is an emergency, we call 911. We give aspirin 300 milligrams chewed because it's much faster to go through. Rest and reassure, and then pain relief to reduce the pain with oxygen. So basically, MONA, morphine, oxygen, sublingual nitrates, aspirin. This is the way we go for in these patients. Sometimes there might be need to give insulin to reduce the risk of stress hyperglycemia. So here, the emerging evidence is that we can give advocates that no elective dental treatment should be given within 30 days of MI. After that, it's safe to be given, but still, it's risky. Now, how to calculate local anesthesia? Now, we should have some facts first. First, 1% lidocaine means 10 milligrams of lidocaine. So the carpool that we have 2% lidocaine, this means it contains 20 milligrams of lidocaine. The 1 to 100,000 adrenaline in a 1.8 milliliter cartridge equals 1.018 milligram of adrenaline. These are basic facts. Now, let's have an example. 70 kilograms male patient. First, we should have the weight multiplied with the maximum allowable dose per kg. The weight is 70, the maximum for lidocaine is 7 milligrams per kg with adrenaline, 4.4 without adrenaline. There's a table that has the articaine, the same thing, and these are the most commonly used here. So 7 by 7 equals 490. The second, the amount of adrenaline, the amount of local anesthesia in the cartridge. This is a basic fact. There's nothing to change in it. But how do we have it? 2% lidocaine equals 20 milligrams lidocaine. We want it milligram per milliliter. So 20 milligram multiplied with the size of the cartridge gives us 36 milligram lidocaine per cartridge. So now divide the 490 over 36 equals 13, nearly 13 cartridge. So basic things is that the second will be always the same if we're using lidocaine. 36 milligram per cartridge. This will always be the same. The first is the one that might change the weight and the allowable dose, and then it's easy to go through. Now, the maximum allowable dose of adrenaline in a patient who is cardiac is 0.04 milligrams of adrenaline, which equals 2 carpools and a little bit of the other one, because as we said, we have 0.018, so about 2 doses, 2 cartridges, and slightly a little of the third. Now, hypertension, it's a persistent high blood pressure, which means above 140 over 90. Usually, it's cardiac output multiplied with the peripheral resistance. We have idiopathic or essential hypertension, in which we have no idea what the cause is, about 90% of the cases, and 10% about secondary hypertension, in which we know the cause, mostly renal disease, around 80% of the 10%. So the old classification had that class 1 hypertension should be 140 to 159 over 90 to 99, 160 to 179 over 95 to 109. This is what we call stage 2 hypertension. Here we don't use a lot of adrenaline. Sedation may help, but we recheck blood pressure and seek medical consultation. Over 180, over 110, we recheck the blood pressure, but we do not do any procedure for this patient. The newer classification has a different way. The normal is less than 120 and over 80. Elevated 129 up to 129 over less than 80. Stage 1 hypertension is 130 to 139 over 80 to 89. Stage 2 over 140 and over 90. This is stage 2 and needs medical management. Patients might have symptoms about 1/3 of the population. This is called the silent killer because patients do not know that they have them. The coronary failure might be a complication, MI, heart failure, all of those can be complications of hypertension. The treatment we go through medications and lifestyle modification, cutting out salts, cutting out any excess fluids, and so on. Then medications like alpha blockers, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, vasodilators, a lot of other medications. Now, the complications of some of these medications include like ACE inhibitors and ARBs can have angioedema of the lips. Calcium channel blockers may give gingival swelling, diuretics, dry mouth. Now, beta blockers, calcium channel blockers, and clonidine, these should be continued in the perioperative period if we're going for GA. Diuretics or ACE inhibitors and angiotensins should be held on the morning of the surgery if we want hypertension to be present. Now, for hypertension, we usually go through late morning appointment and upright position. Now, usually, you need to remember that we have local anesthesia that will raise the blood pressure. So if the patient has 150 over 95, with local anesthesia, this blood pressure will raise even more. So this is risky. But if I'm doing a filling, if I'm doing a small amount of anesthesia, it's fine. If I'm going for extraction, if I'm going for something like that, no, it's better not to go through this procedure at all. So it's a relative point for the surgeon, a clinical decision for the operator. If you find the patient safe to go through management, perfect, we go through it. There are some problems with hypertension called hypertensive urgency and emergency. The urgency in which there is severe elevation of the blood pressure over 180 and over 110, but without any progressive end organ failure. The emergency, more end organ failure will be present, and there will be non-selective beta blockers to manage it. Usually this happens in the ER. Arrhythmia, the normal is 60 to 100 beats per minute. Less than that is called bradycardia. Over 100 is called tachycardia. Now, risk factors for tachycardia: alcohol, atropine, caffeine, epinephrine, and nicotine. Bradycardia, beta blockers, calcium channel blockers, and digitalis and morphine. Usually the only one that we treat the patient with supine position. Mepivacaine is safer in these patients. Usually we go for local anesthesia because if it's tachycardic patient, if it's under GA or sedation, there should be tachycardia during the surgery. If it's brady, it should be brady. Now, some of these patients might have a pacemaker. This might interfere with any electric or cautery that might be used. So these are contraindicated with the pacemaker. Now, infective endocarditis is a predominant affecting life damaged valve. It affects the damaged heart valve. Usually there will be vegetations, bacteria over the damaged valve, and it's life-threatening. There will may be pallor, anemia, fatigue, hepatosplenomegaly, cafe au lait pigmentations. The most common cause for bacteremia, that the bacteria enters the bloodstream, is due to dental extraction, then periodontal surgery, and then scaling and root planing. But nice guidelines, they said, okay, look, chewing food can have a risk of bacteremia, which is something we always do. Teeth cleaning by us can have bacteremia risk. Use of wooden toothpaste, water irrigation devices, toothbrushing and flossing, all of those can induce bacteremia in the blood, can cause bacteria being present in the bloodstream. So why should we give the problem of antibiotic prophylaxis? Now, ADA had the 2007 guidelines said that we should go for antibiotic prophylaxis to prevent an infection of the prosthetic valve that's present In cases of history of infective endocarditis, artificial heart valves, unrepaired cyanotic congenital heart defects, completely repaired with prosthetic material in the first 6 months after the procedure, repaired congenital defects with residual defects, cardiac transplantation, who develop heart valve dysfunction. In these cases, we must give antibiotic prophylaxis to prevent an infection. In the NICE guidelines in 2016, they said no need for antibiotic prophylaxis because risk of resistance for the antibiotics, because of the adverse reactions, as we said, increased risk of resistance bacteria, and we still have bacteremia due to daily activity like brushing, tooth flossing, and so on. But still, we go with the ADA guidelines. Now, antibiotic prophylaxis should be given if the patient is able to take oral medication and non allergic to penicillin, amoxicillin 2 grams. If the patient is unable to take oral medication, ampicillin, ampicillin 2 grams, cefazolin, ceftriaxone 1 gram. Allergic to penicillin, cephalexin 2 grams, clindamycin, azithromycin, clarithromycin. Allergic and unable to take oral medication, cefazolin or clindamycin. But now clindamycin has no longer any role because clindamycin can cause a lot of problems, including the Clostridium difficile infection, which would be very difficult to manage. So they got rid of the clindamycin. Now we can go for azithromycin or clarithromycin, doxycycline, cefazolin or ceftriaxone, or cephalexin. Now for heart failure, we should never use bupivacaine because it's cardiotoxic, and the GA is contraindicated because the heart will not be able to function properly. Bleeding disorders, we have the intrinsic pathway and the extrinsic pathway, as we all know. Now we have three layers of hemostasis. The primary, vasoconstriction after the injury to reduce the amount of blood lost. Secondary, the formation of the fibrin through the coagulation cascade. The tertiary, formation of the plasmin responsible for fibrinolysis and destruction of the fibrin after the layer has formed. How to manage postoperative bleeding? Pressure first, cold second, suture and local anesthesia third. If did not stop, then consider systemic causes. Now, one of the common problems that we have is hemophilia. There is hemophilia A, B, and C. In all of them, we should have normal PT, normal bleeding time, because the platelets are not affected. There will be prolonged PTT, reduced factor 8 in hemophilia A, reduced factor 9 in hemophilia B, and reduced levels of von Willebrand factor. Now, for dental alveolar surgery, we should have a factor 8 level of 50 to 75 of the normal. Warfarin, it's a vitamin K antagonist working on factors 10, 9, 7, and 2. It needs 8 to 12 hours to work, the peak at 36 hours and lasts for 72 hours. INR is the PT of the patient over the PT of the normal. If INR is more than 2.5, what is the protocol to use? We will talk about it in a second. And the antidote is vitamin K. It's a vitamin K antagonist, so to counteract it, we should have vitamin K. Now, we should have the INR checked 72 hours before the procedure. If we are going for a major surgery, we can stop warfarin 4 days if it's safe and without any other medications. Sometimes we go for stopping warfarin 4 days before the procedure. We bridge with enoxaparin. 1 milligram per kilogram twice daily, then resume warfarin after surgery. In the morning of the procedure, we stop the enoxaparin, the night of before and the morning of the procedure 2 times. Now, unfractionated, we stop it 6 hours before the procedure, and local hemostatic measures should be used. Warfarin should not be used with a lot of medications. For example, analgesics, aspirin, nonsteroidals, tramadol, these are bad for warfarin. They are contraindicated with warfarin. So, we go for celecoxib, codeine, and paracetamol. For antibacterials, amoxicillin plus clavinic acid, amoxicillin, ampicillin, tetracyclines, a lot of medications. Azithromycin is safe, clindamycin and erythromycin is safe. Other amoxicillin and penicillins other than amoxicillin and ampicillin, and cephalosporins like ceftriaxone can be safe. Antifungals, amphotericin and nystatin are safe, the rest are not. So there are a lot of medications that go through. Now, if the INR within 24 hours of the procedure is less than 3.5, some suggest less than 3 and some suggest less than 2.5. We do not change the warfarin. We keep the patient as it is. We keep him on warfarin. We do the procedure, extract, then use local hemostatic measures, pressure, collagen sponge, and suture, and wait 30 minutes to check if there is no bleeding. Heparin has a half-life of 6 hours. There's the standard, the low molecular weight. If it's uncomplicated 1 to 3 teeth, no need to interfere with it. The antidote is protamine sulfate. For the aspirin, we no longer stop it. We keep the patient on it. It's an antiplatelet. Now, the newer generation is called novel anticoagulants. They do not require monitoring. No need for interruption for most dental treatments. Low risk, like simple restorations, local anesthesia, scaling, single tooth extraction. Moderate, 2 to 4 teeth, gingival surgery up to 5 teeth. Higher risk of bleeding, general surgery or major surgery, multiple dental implants, generalized gingival surgery, more than 6 teeth or extractions. Now, if it's an invasive, we can stop edoxaban or rivaroxaban for 24 hours before and apixaban 48 hours before the procedure. And we reinitiate it on the same day of the procedure. Now, the non-vitamin K antagonist, we have direct thrombin inhibitors like dabigatran and the factor 10A inhibitors like rivaroxaban, apixaban, edoxaban. Now, as we can see, the X in the rivaroxaban and the apixaban, these are the ones that differentiate this medication. So, meaning, I can know this is a factor 10 inhibitor by looking at the name. Now, this is a recombinant coagulation factor 10 inactivation, and this is the antidote for these medications. They have an antidote. It's called idracizumab. This is for the factor 10 inhibitor, for the dabigatran, sorry. The Andexa is for factors 10 inhibitors. Andexanet alpha, which reverses factor 10 inhibitors. The idracizumab for the dabigatran. Now, platelets should be more than 25 for local anesthesia, for simple over 50, and 75 for major surgery. Now, endocrine, as we know, we have 3 types of DM. There are multiple complications. We have the acute ones: hypoglycemic coma, rapid onset, strong bounding pulse, and irritable patient before consciousness is lost. The hyperglycemic coma, drowsiness, acidosis, and ketone breath. Now we give, if the patient has a hypoglycemic shock, we give 25 grams of glucose orally or 20 milligram 20% to 50% dextrose IV or glucagon 1 milligram IM. If the patient is hyperglycemic coma, we give saline. There are some chronic complications of diabetes. The general management, usually we need to check the level of glucose. As we all know, patients who are diabetic are 6.5 HbA1c or above, 126 or above for fasting and for the tolerance test, and the random over 200. To manage it, usually losing weight, diet changes, and oral hypoglycemic agents. For patients with for DM patients with dental treatment, early morning appointment must be present. Taking the medication and taking his breakfast, eating good before coming to the procedure with his medication, of course. And if there's an emergency, we consider hypoglycemia. Now, corticosteroids are used to suppress inflammation, to suppress graft rejection, and to replace missing hormones. Now, there are multiple types of corticosteroids. We have dexamethasone, betamethasone, these are long actings, triamcinolone, 5, medium acting prednisolone, methylprednisolone, and cortisone, these are short acting. Now, there are two rules if we need to go for suppression, for covering the patient with corticosteroids or not. Now, if the patient starts to take exogenous corticosteroids above a specific limit, the body will stop to secrete the corticosteroids. That's why, if the patient has been on daily systemic corticosteroids above 5 milligrams of prednisolone, if the patient has been taking them regularly over 30 days, the previous one, or more than a month within the past year. Now, if it's conservative dentistry or single tooth extraction under local anesthesia, patient should take the steroid dose in the morning normally with hydrocortisone 25 to 50 milligram intravenous before the procedure. This if the patient has been taking them during the past 12 months. If he's already on them, double the oral dose with coverage preoperatively, 25 to 50 milligram hydrocortisone IV, then normal steroid medication postoperatively. He takes it twice a day, he keeps on it. If it's intermediate surgery under GA, we should go for the cover, double if it's if the patient is already on them, with hydrocortisone and 6 hours intervals. If maxillofacial trauma or surgery, we give double and 6 hourly for 72 hours rather than 24. So, need or no need for cover. There is the rule of two as well. If the patient has been taking at least 20 milligram cortisone or its equivalent daily for 2 weeks or more within 2 years of dental or surgical treatment. So, mainly, to summarize, if we're going for a general conservative treatment, we should just double the oral dose in the morning and give the patient preoperatively hydrocortisone. If we're going for an intermediate surgery, double the oral dose in the morning, 6 hours intervals hydrocortisone, and then for 24 hours. the maxillofacial surgery or trauma, double the oral dose, and then 25 to 50 for 72 hours IM or IV. The thyroid, we have hypothyroidism and hyperthyroidism. For hypothyroidism, usually raised levels of T3 and T4. Lidocaine is safe. Prilocaine is safe as well. Povidone iodine should be avoided. Agranulocytosis might happen. And if it's controlled, then we can go with the treatment. If it's not controlled, we should not go with the treatment. Now, philiprison is safer than lidocaine with epinephrine. So we go for prilocaine with philiprison because it's slightly less destructive or slightly less affected by the thyroid. We go for the lidocaine alone, it's safe, but epinephrine adding it would be difficult. For hypothyroidism, same, if it's controlled, we should go. If it's uncontrolled, we shouldn't treat the patient. Myxedema risk problem and povidone iodine problem. Now the last part, the pregnant patients. Gingivitis, dental caries, granuloma may be present. Radiographs are considered safe for the pregnant patient, but shielding is no longer recommended. So we have categories for the medications, category A, B, and C, and D. A, no risk in humans, either pregnant individuals showed no problems or animal studies. Category C, no, the risk cannot be ruled out. The animal or the human controlled studies, the human are lacking, but with the animal are present, and there's risk on the fetus. The actual risk on the fetus is contraindicated. Now, category A, folic acid, vitamins, and so on. Category B, penicillin, ciprofloxacin, doxy, erythromycin, clindamycin. Newly, metronidazole has been used to be safe in the second trimester. For anesthesia, lidocaine and prilocaine are category B. Mepivacaine, articaine, and bupivacaine are category C. Antibiotics, clindamycin is category C. And B. Now, as for the categories, category A, the drugs that are safe during pregnancy, the vitamins. Category B, as you can see, the antibiotics like penicillin, amoxicillin, doxycycline, levofloxacin, cephalosporins, erythromycin, clindamycin, metronidazole. Now, clindamycin is present in category B and category C. So we should be careful with using it. So we go for the amoxicillin, amoclan. These are actually safe. Metronidazole, a lot of studies have said that it's safe, but safe to be for a specific limit because it's the one that treats Clostridium difficile. So how can you give any other medication to treat it? That's why they kept it to be safe, but in a specific amount. For anesthesia, we lidocaine and prilocaine are category B. The lidocaine, prilocaine category B. For category C, we have mepivacaine, bupivacaine, and articaine. Now, in category B, the analgesics acetaminophen is safe. Ibuprofen, they are considered safe in pregnancy, but preferably not to be given. Warfarin is safe, sometimes they give it, and so on. So the most important messages in this case is always spend time listening to your patient and treat elective cases in good phases. Here are the references if in case you need them, and thank you.